be presenting several talks on different topics. So this is a kind of multi-speciality symposium, and we want to thank All India Ophthalmology Society for the kind invitation to present this Russian ophthalmology symposium during the All India Ophthalmology Conference in Calcutta. So let me introduce my colleagues, starting from right to left. We have doctors from different cities. This is Dr. Batkov from Cheboksary. We a group of three, me, myself, Professor Izmailova and Dr. Antonova from Moscow, and one more person, Dr. Katmakov, is also from Cheboksary, and we have another nice lady who is representing St. Petersburg. So we have different schools here and different topics. So I would like to present the first talk, and that will be related on limbal stem cell deficiency.
Boris, I just would like to add that Professor Malugin is the president of the Russian Ophthalmology Society and well known around the world. Please welcome.
Thank you very much. So I will be talking today about the femtolaser assisted technologies of limbal stem cell deficiency in limbal stem cell deficiency patients via epithelium reconstructive surgery. This is just to remind you the complex structure of the limbal area, which we know generates the limbal cells covering the cornea, and this layer is vital to getting the cornea transparent and completely clear. We know the XYZ theory, when epithelium cells that are generated by stem cells are migrating towards the center of the cornea from the periphery, and from the lower, deeper parts of the epithelium layers to the surface, and then exfoliated out from the superficial areas. And these are very nice pictures showing that the epithelium cells lines are colored in different stains, generates their own lines of cells like green, red, and blue that migrates from the limbal area towards the center and then covers the whole cornea. We know that limbal epithelium stem cell deficiency is a complex disease which is related to many congenital and acquired factors. Among those, we have to mention ocular burns and traumas and different long-term of use of medications. So corneal revitalization techniques depend on the laterality of the lesion, and we will be talking today about unilateral limbal stem cell deficiency that can be reversed by surgery or different regenerative procedures, and there are different methods of surgical procedures that were being introduced over these years, with probably the most widely used that is coming from India by Dr. Sangwan and co-authors who pioneered the simple limbal epithelial cell transplantation, or SLET technique, when the eyes, when the cells from the limbal area of the normal eye transferred to the surface of the affected eye. Following that, the lens, the cells are glued on top of the amniotic membrane, and following that they spread and restore the function of the damaged and lost cells. And we know that it provides both anatomical and functional success in substantial amount of patients. Over 70% of patients regain their normal ocular surface, including pediatric cases and adult patients. So in 2020, we published the new variation of this simple limbal epithelial cell transplantation, which is called glueless, because the simple idea here was that we were not having at that time the glue that was appropriate for gluing the limbal fragments towards the cornea. So we decided, why don't we create the non-penetrating incisions on the periphery of the cornea and to place these limbal microfragments harvested from the healthy eye into these non-penetrating tunnels, thus creating a specific niche for epithelial stem cells that will be located in these tunnels. So here is the procedure. As you can see here, we are doing intraoperative OCT to verify the damaged area of the cornea, and we are excising now the pannus from the surface of the cornea, and sometimes the corneas may be more or less affected, so it depends on the lesion, of the agent, of the chemical agent that created this limbal stem cell deficiency. Some polishing may be needed to smoothen the surface of the cornea, and cautery is applied to avoid bleeding. So following that, we take the limbal limbal fragment from the 12 o'clock position of the healthy eye, and we fragment this piece into 8 pieces. Following that, the partial thickness tunnels are created, and these limbal fragments are introduced into these tunnels one by one, and usually this at the end of the procedure, we cover the cornea with amniotic membrane and contact lens. So this is the latest publication that we have. We analyzed results of this procedure in 14 eyes of over 6 months, and you can see here that we have a good result, including full reepithelialization of the cornea in more than 60% of cases. In more than 32%, it was almost complete reepithelialization, but there were some failures, of course, that we were followed for another procedures that we've done. So obviously, with restoring the normal epithelium, we have decrease of the tearing, photophobia, and all other negative side effects and symptoms of the limbal stem cell deficiency. So this is the next technology. So we decided why to use these tunnels manually, and we created, with the help of the engineers from Zimmer, special software that help us to create non-penetrating corneal tunnels with laser, and you can see these tunnels created on the porcine eye in a radial fashion. So this is how the procedure looks like. We dock After removal of the panels, we dock the laser and we create the incisions with the help of this laser. And you can see on OCT, we can see the nice tunnels and the air bubbles inside these tunnels. We use the spatula to open these incisions and then implant the limbal fragments into these incisions one by one. And you see how on the OCT it's possible to visualize the incisions the fragments located inside the incisions. So these are some of the results, preoperative and postoperative view of the eye after 6 months post-surgical procedures. And this is case 1, case 2, case 3, and case 4, and there are many more that we have. So the next step was to avoid knife not only during the process of creating the tunnels, but also during the process of harvesting the epithelial cells. As you can see here, there is a niche of the epithelium stem cells in the limbal area where palisades of wax are located. This niche is 100 micron from the surface of the limbal area. So then we can program the laser and create a very nice and precisely controlled fragments with the laser. So this is a schematic representation of how the laser work, and this is again the other software that helps to create these limbal fragments. And again, this is animation showing what was already being shown, how these limbal fragments are implanted into the corneal tunnels. So basically, this is how the software works. So after docking, we have exposure of the sclera and the limbal area, because there is a need to excise conjunctiva. And this is after laser. We remove the corneal scleral fragments one by one, because there are some adhesions exist in this area. This is one of the first clinical cases. You see, this is 2 weeks postoperatively. We have partial epithelialization, 1 month as well. So in 2 months, the epithelialization of the cornea was like 3/4 of cornea were already healthy, and this is 3 months postoperatively, and we see that there is a complete coverage of the cornea with the healthy corneal epithelium. So to conclude, it's an interesting area of research, and there are several techniques that are proposed to cure these patients. So there are different approaches depending on the laterality of the disease and the underlying conditions. However, we do think that femtosecond laser-assisted technologies are quite a viable option and help us to treat these patients quite effectively. And I thank you very much for your kind attention.
Thank you. Thank you. I think we'll go on for the second talk, and shifting gears, we'll go to the back side of the cornea, and we invite Dr. Olga Antonova to deliver her talk titled Transplantation of Native Corneal Endothelial Cells in an In Vitro Experiment. Sorry.
Good afternoon, everyone. And first of all, I would like to thank Indian colleagues for the invitation, and it's a pleasure to speak in your professional society. And I will start my report. Today, there is only a surgical option for the treatment of endothelial corneal dystrophy, which include Fuchs corneal dystrophy and pseudophakic keratopathy. Among keratoplasty techniques, in addition to classic penetrating keratoplasty, distimate stripping endothelial keratoplasty using a microkeratome or femtolaser and transplantation of distimate's membrane with endothelium are most often performed, and less commonly transplantation of a fragment of distimate's membrane, for example, hemidemic or quarter-demic, is performed, or the donor endothelium is not transplanted at all and only distimatorexis is performed. But despite the high results of these surgical techniques of keratoplasty, they have some disadvantages. For example, damage to the donor graft during preparation or during its transplantation, and also detachment of the endothelial graft in the early postoperative period. These problems initiated the search for ways to isolate and cultivate corneal endothelial cells, which is still relevant today. In 2014, Japanese scientists transplanted cultured corneal endothelial cells using a ROCK inhibitor and patients with pseudophakic dystrophy. A required condition was a forced hand-down position for 3 hours, and they showed results in follow-up periods of 2 and 5 years postoperative period. And this slide shows photos of all 11 eyes before cells injection and 2 years after. 5 years after surgery, normal corneal endothelial function was restored in 10 of 11 eyes. It should be noted that in Russia we have a law that restricts the use of cultured cells products. And the restrictions are very strict, and we can say that this law practically prohibits the use of cultured cells. That's why we have developed a method for getting a suspension of native endothelial cells. These techniques involve the primary separation of a roll of distimate's membrane with endothelium. Then the distimate's membrane is placed in a solution of chemically stable trypsin, and after that, using the thermoshaker device, endothelial cells are knocked off the membrane. The cells settle at the bottom of the tube, and then we washed the cells from the enzyme solution, and in this form they can be transplanted. On this slide, you can see the result of confocal microscopy with staining of living and dead cells, and there are obviously more green living cells. Also, in addition to assessing the viability of the obtained endothelial cells, we analyzed the cell suspension for contamination. And according to our conclusion, the developed method makes it possible to get a pure cell suspension. After obtaining and assessing the quality of the cell suspension, we performed a series of experiments to simulate the transplantation cell suspension. The first part of the experiment was done on a trifund corneal scleral disc, and this slide shows the stage of staining distimate's membrane with trypan blue dye to assess the primary condition of the endothelium. We know that when there is a high density of endothelial cells, the blue stain will not be bright because the cells don't absorb the dye and only distimate's membrane absorbs. Next, we remove the endothelial cells using a microtapher and an irrigation flow with an approximate diameter of 6 millimeters. After removing the endothelium, we restain distimate's membrane, and a bright blue color indicates the absence of endothelial cells on the surface of distimate's membrane. And this is how we modulated a potential patient with endothelial dystrophy. For transplantation of endothelial cells in suspension, we took 0.1 milliliters of this, and using the cells counter device, we found that this volume of suspension contains approximately 100,000 cells. For transplantation, we used a glass cannula because it is the safest for cells during their passing. Before transplantation, the suspension onto the corneoscleral disc, we previously determined that 10% of cells are lost when passing through a glass cannula. After transplantation of the suspension, the corneoscleral disc was left in an incubator for 4 hours, and after that time, the suspension was taken and the cells were recounted, and approximately 36,000 were obtained, which is 40% of the initial number. So the adhesion of endothelial cells in the experiment was approximately 54,000 cells, that is 60% of the initial number. Why did we take 100,000 cells in 0.1 milliliter suspension initially? We needed to fill an area of the cement membrane with a diameter of approximately 6 millimeters with cells, and we know that the average density of endothelial cells in a healthy cornea is about 3,200 cells per square millimeters, and after the calculation we obtained the required number of cells. At the end of the first part of the experiment, we performed a scanning electron microscopy, and based on the results of which we determined obvious differences in the microstructure of the physically healthy endothelium and the one we transplanted. And this indicates that there are no primary endothelial cells of the corneoscleral disc, and the cells that we see on electron microscopy are transplanted donor endothelial cells. The second stage of the experiment we performed on the cadaver eye, and first we removed the epithelium from the cornea. After that, we marked the required diameter of 6 millimeters, and next the surgical incision was made 2 millimeters wide. Using a Sinskey hook, we removed the endothelial cells, trying not to damage the cement membrane. And after this, we inject trypan blue dye to see the cement membrane area after removal of endothelial cells. Next, using a glass cannula, we took 0.1 milliliter of a pre-preparated cell suspension and injected it into the anterior chamber of the cadaver eye. The surgical incision was sutured, and we turned the cadaver eye upside down. The cornea was placed upside down position in an incubator for 4 hours. And next, we trypanated the corneoscleral disc, and it was sent for cultivation for 7 days. We have to say that cultivation was necessary only to determine the availability and phenotype of the cells in the experiment. At the end of the second stage of the experiment, we received the results of scanning electron microscopy and immunohistochemistry, and transplanted endothelial cells adhered the completely closed the form defect, and the functionality of these cells is confirmed by the expression of 2 main proteins of endothelial cells. And in conclusion, we have to say that according to the circle formula and based on the minimum allowable amount of 500 cells per square millimeter, only about 15,000 cells are needed to fill a defect with approximately diameter of 6 millimeters. In the first and second stage of the experiment, 100,000 cells were transplanted into 0.1 milliliter of suspension, which according to the results of scanning electron microscopy and immunohistochemistry made it possible to achieve endothelial cells adhesion in the formed central zone of the defect. At the same time, in the research of Japanese scientists, 1 million cells were transplanted in suspension, but it was cultured cells. Considering the possible ways of cell loss that have not yet been studied, for example, at the implantation stage or adhesion to the structures of the anterior chamber, migration to the posterior segment and trabecula, and etc. The further task of our study is to get the maximum number of endothelial cells in suspension to achieve the primary goal, corneal edema resorption. And thank you for your kind attention.
Thank you very much, and we will continue with the next talk related to the cornea, and this is the talk related to treatment of keratoconus and several new technologies that are coming from our clinic.
It's not working. Maybe the other.
Okay.
Измайлова Светлана. Thank you very much. And good afternoon, dear colleagues. And in beginning, I want to say that I am so glad to take a part in this grandiose All-Indian Ophthalmology Congress, and I will glad to present my my speech today. And today we are going to discuss three perspective methods for keratoconus treatment. Is for pediatric keratoconus in child, for advanced keratoconus, and for prevention of recurrent keratoconus and ametropia after keratoplasty due to keratoconus. And let's start from children. And I want to say that the course of keratoconus in childhood is characterized by great aggressiveness and higher rate of course. And corneal segment implantations have been successfully used since the 19th years in the treatment by progressive keratoconus in adults, but in children since 2005. And UV cross-linking in children has been used since 2008. And my presentation is based on my personal experience since 2012 intracorneal ring segment implantation and corneal cross-linking for kids. And I want to say that keratoconus in childhood is characterized by the development of amblyopia, which is permanent outcomes in adulthood. And so I think that we must treat keratoconus in child as early as it is possible. I think so. And based on the previously mentioned factors, we proposed a combined technique, intracorneal ring segment implantation with a corneal cross-linking in childhood on 30 eyes. Maximum follow-up period is 1 year. As you can see, the first step is femtosecond assistant intracorneal ring segment implantation. The second step is then mechanical epithelium removal, and the third step is installation of riboflavin solution into the interstromal channel. Finally, epi of cross-linking we proposed. Our research is based on corneal cross-linking in childhood and 70 eyes. Maximum follow-up period is 10 years. 52nd assistant intracorneal ring segment implantation is 75 eyes, and maximum follow-up period is 12 years. And presented 52nd assistant intracorneal ring segment implantation combined into one step. It's operation with the corneal cross-linking in childhood, 30 eyes, maximum follow-up period 1 year. And we compared 3 different methods, and you can see that a dynamic of visual acuity is faster in the method of one-step operated and intracorneal ring segment implantation and UV cross-linking. And you can see dynamic of keratometry, dynamic of corneal thickness, and as results, in all cases, there was stabilization of keratoconus and improvement of clinical and functional results, and progression of keratoconus absent even the longest follow-up period up to 12 years. During intracorneal rig segment implantation, BCVA and UDVA increase for a long time, which is extremely important for the formation of the visual analyzer in the childhood. We recommended the maximum positive dynamics in the group on one-stage treatment. This includes a significant increase of visual acuity and decrease of keratometry data. So, to recap, combined techniques give us the early visual acuity gain with the 1000 stabilization of the process. The post-operative period is less stressed. The proposed method reduced the number of hospitalization and anesthesia. No one of patients needed in keratoplasty at all or follow-up period. And the next technology that I want to present today is the femtosecond assisted keratotomy combined with the corneal cross-linking with the patients in keratoconus. And I want to say that this method was proposed by Professor Fedor, but was not widely used due to the fact that in the arsenal of surgeons there was no femtosecond laser surgery and cross-linking. And now we recommended this method for patients whom cannot be performed intracorneal segment implantation due to a thin cornea, but who do not yet have corneal opacity. In support of our words, we present two histological data from patients with keratotomy with normal scarring on the left and in patients with the keratoconus. As you can see, we note the third type of scarring is the patients with keratoconus. To prevent this situation, we recommended perform cross-linking after the laser incisions in one operation. It's combined technology too. And we were the first who developed patterns for applying non-perforated radial incisions using femtosecond laser. We present the video. The first stage is the formation of radial incisions. The second stage is the opening the incisions with a spatula and filling them with the riboflavin after incisions. And after that, we perform the ultraviolet cross-linking, and as a result, the central part of corneals is flattened. Yes. And our studies based in so small analysis is results of 5 patients only with advanced keratoconus who underwent femtosecond assisted keratotomy combined with the corneal cross-linking. In all cases, the progression of keratoconus was stopped for 2 years, and refractive power of corneal decreased, while the thickness of cornea remained unchanged, which indicates stabilization of the process. And I want to say that the number of cases, of course, is extremely small. Preliminary results show the effectiveness of the method, but it's so small, the number of cases, of course. The long-term results with the follow-up period of more than 2 years are presented, and the proposed methods makes it possible to avoid this significantly delay keratoplasty even in the advanced stage of keratoconus. And cross-linking and implantation of corneal segment is not recommended due to non-compliance with the selection criteria. And this method requires further research, of course. And the last method that I want to present today is femtopenetrating keratoplasty with intrastromal ring implantation. And the main criteria for the success of performed keratoplasty is the achievements of graft transparency. However, it's becoming increasingly important to achieve high clinical and functional results after surgery, which directly depends on the degree of ametropia of the operated eye. And I want to say that from 6 to 11% probability is recurrent keratoconus several years after surgery. And the causes of post-keratoplastic ametropia is included the preoperative and intraoperative and post-operative. And methods of intraoperative prevention of keratoplastic ametropia we can see on the slide. And I would like to recall Dr. Krumeich's methods. He implanted a ring between the recipient's residual cornea and the donor cornea, and then performed ring removal during suture removal, which had no effect in preventing of post-keratoplastic astigmatism. And firstly, we performed our technique on cadaver eyes, and after we operated 20 patients, and maximum follow-up period is 5 years. And according to our technique, after cutting our mushroom pattern, the 50-second laser exfoliates towards the residual corneal stroma of the recipient, forming a lamellar pocket where the intrastromal ring is placed, and the disc of donor tissue is fixed then. The results you can see on this slide, and we compared with the standard femto-PK and manual PK, and we noted an earlier increase of visual acuity. And it's interesting that we had an opportunity to take the complex graft and residual corneal tissue of the patients with recurring keratoconus for histology examination during the rekeratoplasty. And I want to say that we prove that the recurrent process starts from the residual stroma. And our techniques give us the earlier improvement of visual acuity. Sorry. And now, prevent secondary ectasia during allocation in the recurrent residual stroma, and the follow-up in 5 years, no protrusions or dislocations of the ring were detected. And in conclusion, I want to say that today we have presented 3 new debatable, of course, techniques for the treatment of keratoconus in various stages. This have demonstrated what? The stabilization of the process and early improvement and visual acuity. And however, this techniques is needed to more examination and confirm the safety and efficacy. And I want to, in the end, I want to say that the motto of our teacher, Professor Svetoslav Nikolaevich Fedorov, was the beautiful eyes for everybody. And this words is our motto in our work too. And thank you for your attention.
Thank you very much. For the sake of time, because the session was delayed, so we will not having any questions. Maybe at the end of the session we can discuss that, and I will ask Dr. Batьков to present his experience in modular IOL of his own design.
Hello, everyone who stays awake in this afternoon time, which is usually a problem. It's ridiculous to say about the time now because we are late for 1 hour, so let me not to fail as much as the organizing committee did. First of all, I would like to introduce my co-authors. These are 2 great guys who did all the surgery in this study. Well, I have to confess that I'm not good enough to suture the cornea, but I'm an expert at cutting it. Well, I think we'll skip some basics, and as you well know, that cornea and lens are the principal parts of the optical apparatus that forms the image on the retina. And when we encounter combined simultaneous cataract and corneal disease, we know some important points in this. As you will understand, refraction is primarily an issue for penetrating keratoplasty, which involves air-cornea interface. The same is true for DALK, which also interferes with the air-cornea interface. We also know that refractive accuracy is far more greater in a stage surgery. And triple procedure we have to encounter in several situations when we see advanced cataract. There could be an argument that PKP is getting a thing of the past, with endothelial lamellar techniques conquering the globe. This view is only partially true. Even in the so-called developed world, the combined share of penetrating keratoplasty and DULC is far from disappearing, approaching 30 to 40% of the total. But when you consider more populous regions of the world, this share rises to 80 and 90%. I think the best tribute to the importance of refractive issues post-keratoplasty is the multitude of approaches developed to mitigate the problem. Everything from spectacles, contact lenses, to repeat transplantations are done in this case. A lenticular part is also a part of the equation. One way, not very popular, not very mainstream way of dealing with the problem is to use modular lenses, intraocular lenses with a replaceable optic. I have to admit that the concept of a modular IOL is neither new nor dead one. The approaches have been tried in the 90s, and they are not dead, and they are still being pursued currently. We have come with our own, and one important piece of logic behind this design is, so to say, manufacturer or technology independence. All of the complexity of repeatable assembly and disassembly of the device went into the haptic part, implanted once during the primary procedure. And that's it, you've got a lifetime IOL support. Whenever the need arises for optical power to be changed, or any other circumstance like clinical change or technological development, there's a permanent optic holder permitting any discoid-shaped device to be implanted in the future. It is in fact an open platform, not particularly restricted to any specific manufacturer or technological process. And importantly, the design also boasts unlimited optic rotation, which is toric compliant. These are some technical details of the implant, which are pretty standard. Notable is the hydrophobic nature of the material, which is important for posterior lamellar techniques. The optical disc is 5.5 to accommodate a larger haptic ring around it. So the purpose of our study was to evaluate clinical feasibility of primary modular IOL implantation during combined cataract and keratoplasty surgery. There were 36 primary implantations in this study, with a preponderance of females among the subjects. We have not done optic exchanges yet. Age distribution is heterogeneous from late 40s to late 80s, and current overall follow-up is rather short, with half of cases less than 3 months after the surgery. The indication table is a snapshot of our patient base dominated by full thickness opacities, scars, multiple graft failures, a bunch of perforating ulcers, and chemical burns. We start our video gallery with a DMAC case, illustrating the advantages of phaco in a closed environment, taking advantage of the foldable nature of the implant, which is assembled ex vivo in a dry setting. The assembly process is pretty straightforward, short, and minimally interfering with the standard protocol, as you can see on this video. It's implanted in the cartridge in a methyl cellulose containing viscoelastic, and in a standard fashion implanted into the bag with little manipulation to deliver the trailing haptic. And the DMAC part is finished in a regular fashion with stripping Descemet membrane, injecting the graft, and lots of tapping and prayer. This acute eye drops case with a nuclear cataract requires a completely different skill set. Still, there's a place for a controlled capsular opening, as you can see here. Yeah, the nucleus is expressed by Hydro procedure. And even there's a place for automatic cleanup. The pre-assembled lens is placed into the bag, step by step, in an open sky environment. And the corneal button is securely and hermetically sutured in place. To illustrate the exchange part, I can only show you a vitreoretinal case where the optic is being exchanged at the time of silicone oil removal. The optic is dislodged into the anterior chamber, the tunnel is refreshed, the optic cut with IOL scissors, and removed. The replacing optic goes in a standard fashion and by manually guided into its place under two fixation leaflets that hold the optic in place. We just check out the first one. In this study, we were obviously lucky not to see any major IOL-related issues like dislocations, spontaneous disassembly, implant damage during implantation. There was one case of fibrinous membrane around the implant. Though we have to admit this study was not designed to measure such important things like uveal biocompatibility, power calculation accuracy, and relation of the optic to the eye's visual axis. When collecting the data for this presentation, I was amazed at how ill the cohort was cornea-wise. We've got a fifth of grafts failed, multiple persistent erosions, even a psychiatric patient rubbing his eyes obsessively. So that's why we got a lot of wound dehiscences in this study. There were some non-corneal secondary surgeries for the pre-existing conditions that accompanied these patients. In refractive terms, we reasonably got a dispersive picture. The lamellar cases shown in red stand out by being close to zero, while penetrating ones landing anywhere from +10 to -6 sphere, with the majority of cylinders in the up to 4 diopter range. Not pretending to be talking about a universal one-fits-all solution, still in the process of mental digestion of the outcomes, we envisioned that modular IOL approach adding value to high-risk patients undergoing penetrating keratoplasty in an inflamed environment where cataracts develop early and grafts fail easily. High life expectancy is a dominant hardcore factor. Simply having more time for an eye to develop refractive change, world to experience a technological revolution, and brutally for a graft to fail makes a tremendous difference. Possibly, we can also look at elder patients with endothelial disease and rather clear lenses, knowing that within 3 years of corneal transplantation, they will require cataract surgery. If we can undeniably prove that optic replacement is safer to a transplanted cornea than a full-scale cataract removal. Well, to summarize, keratoplasty patients with cataract present difficult refractive challenges. Primary modular IOL implantation is minimally disruptive to common operative technique and has a good safety profile. Cylinder correction is a must for a device aiming for a keratoplasty population. We're still early on the data acquisition curve regarding optic exchange, and time is also needed to prove the long-term stability and centration of the implant, its capacity to maintain durable assembly, disassembly capability. And thank you very much for your attention.
Thank you very much, Dr. Badkov. Our next speaker, Dr. Katmakov, will be sharing his experience with femtolaser-assisted deep anterior lamellar keratoplasty.
Hello, highly esteemed colleagues and conference listeners. For me, it's a great honor to speak here at the conference of All India Ophthalmological Society. Let's just imagine you and 9 other eye surgeons enter the operating room, and you see that you need to perform deep anterior lamellar keratoplasty. It means that you need to get as close as possible to the descendant membrane and the endothelium without damaging the membrane integrity. Right now, 10 eye surgeons are performing deep anterior lamellar keratoplasty in the different parts of the world. But unfortunately, I will have to disappoint you, and within the next hour, from 1 up to 5 eye surgeons will not be able to complete it and have to switch to penetrating keratoplasty. And who knows, one day you may also be among these 5 surgeons, right? Let me show you something. Here are my first 2 slides. So, can we apply just a little magic and make DLK success rate higher? We know that DLK has a dark hallway of unpredictability and foreseen events, but we can either accept this situation as it is, or we can find ways to change and improve it. And we know that deep anterior lamellar keratoplasty has become an elegant solution for many corneal diseases, exactly keratitis, cornea opacities, of course, cornea dystrophies. And the surgeon's key goal is to leave as little residual stroma over the own recipient's descendant membrane. And of course, the big bubble technique developed by Dr. Anwar and Dr. Teichmann has become the base surgical procedure. We know that the required data have already been found, and the direct interconnection has been proved, which can be described as the thinner the better. It means that the less stroma will leave over the descendant membrane, or what's ever better, if the descendant membrane is completely exposed, the smoother donor-recipient interface and the high visual acuity and visual quality can be. What to do if perforation occurs? We know that all perforations can be large, small, located in the center, or located on the periphery. In 2018, at the Cornea Day in Moscow, professor from Italy, Vincenzo Cernicolo, presented an outstanding report. In this report, author presented various technical solutions and provided data of the frequency of cornea perforation, which ranges from 4% to 39%, and the frequency of forced transition from DLK to penetrating keratoplasty from 0% to 60%. Option number 1, what we should do if we see peripheral macroperforation. Initially, it can be a helpful step if we not injecting air. In the same report, Professor Cernicolo presented his own algorithm, which includes 2 steps. First step, suturing the donor stroma and only then inject the air into the anterior chamber. Option number 2, peripheral microperforation. In this situation, we don't see the gross deformation of the dystemic membrane, and that's why this situation allows us to continue the surgery. But we still should be ready to perform the second stage of the surgery in 1 or 2 days. In the situation when we see a double anterior chamber, namely we drain the fluid and inject a gas-air mixture into the anterior chamber. Option number 3, central microperforation. Central microperforation can be a real challenge, and each of us knows the frustrating feeling of having to switch to penetrating keratoplasty, and in this time we may feel confused. You may get even more confused if you have persisted and continue the DLK and try to bring the edges of the dystemic membrane closer together. And at the end of the surgery, you will see the bad dystemic membrane, and you have to make another tough decision to use the second donor material and redo the whole process within penetrating keratoplasty. But sometimes we can be successful. The fourth option, we can describe the situation when we see central microperforation. This case can be useful initial injection of air. This is my clinical case. It's a patient with keratoectasia, namely keratoconus stage 4 and central corneal thickness 388. First step was the femtosecond laser dissection of the stroma. Then a tunnel was formed manually for further injection of air, and the first attempt ended up to be unsuccessful. The second one worked out. But at the moment of stroma separation, we noticed a flow of fluid from the anterior chamber, and in this situation, injection of air led us to visualize the defect and led us to complete the process of preparing bed for donor stroma. We know that there are situations when with complete transparency of donor-recipient complex, it's not possible to achieve high visual acuity, and any central defect doesn't make the situation optimistic. After 3 months, visual acuity was 20/50 Snellen, and applying higher degree of the image, we don't see the formation of scar. The optical zone is transparent. What if we close your eyes, open them, and imagine that there is no perforation? What techniques can help us avoid perforation? First one, DLK removal of stroma from the periphery spirally. The second one, double bubble DLK. The third one, DLK using blunt tip scissors. Another useful technique, the technique groove and peel. Summing up the set above, the following tricks can be used in practice. In case of peripheral macroperforation, initially not injecting air. In case of peripheral microperforation, we can continue the surgery but still should be ready to perform a second stage of the surgery. In case of central macroperforation, we can make an attempt to bring the edges of the systemic membrane together or be ready to switch to penetrating keratoplasty. And in case of central microperforation, initial injection of air. Some useful techniques you can see on the slides. And is it difficult to perform keratoplasty? Definitely yes, but it's not impossible. At the beginning we said that from 1 up to 5 eye surgeons have a potential to not to complete DLK. And we are able to change this number, and at least 1 or 2 more surgeons will achieve the success. It will already be a big victory. Thank you all.
Thank you very much for your interesting talk, and we have the last one from Dr. Mirsaitova, St. Petersburg, sharing us using femtosecond laser for refractive surgeries.
Good afternoon, dear colleagues. Thank you for invitation and allow me to present a report. Myopia and high myopia estimates from 2000 to 2050 significant suggest increases in prevalences globally. Refractive lenticular extraction technology is becoming increasingly popular as a flapless and minimally invasive form of laser vision correction for the treatment of myopia. 500 kHz VisuMax platform with a pulse energy from 100 to 180 nanojoules is used for SMILE. The purpose of the study was to investigate the optimal femtosecond laser low energy with the aim of improving clinical outcomes during the early postoperative period after SMILE for correction of myopia. Our clinical trials included 123 patients. We retrospectively and prospectively compared the visual outcomes in 3 groups, dividing according to the laser energy levels. Retrospective groups underwent SMILE at conventionally used energy levels of 150 nanojoules, and other 2 groups underwent SMILE using lower energy levels of 140 and 130 nanojoules. All patients underwent a baseline preoperative assessment and additional research methods. Observation periods include 12 months. The operation according to the standard technique were performed by the same surgery. The surgical parameters were as follows: pulse energy from 130 to 150 nanojoules, for distance 4.5 regardless of energy, gap thickness 120 microns, and side cut width 3 millimeters. We also perform quantitative analysis of black areas using computer program. Observe that occurred in the posterior plane of lenticula was divided into 4 levels according to the maximum covered distance. Observe that ocularity in the anterior plane of the lenticula was divided into central or diffuse. Optical densimetry was evaluated using pentagram in different concentric zones and in different depths. The preoperative clinical features of the eyes by groups are presented in the table. All data were collected and imported into statistic for Windows software. Developed a device to determine the force required to dissect the lenticular after SMILE to select the optimal laser energy levels. An experiment was conducted on 25 cadaverous pigs' eyes. 5 angiolar levels were studied. During corneal tissue separation, the spatula acts on the resistive thin film pressure sensors, which are connected to the Arduino unit and transmit all information to the computer using a Bluetooth model. The results of all sensors are displayed on the screen in the form of graphs. The results of comparing the groups are presented in the table. It was found that the use of high energy levels was accompanied by easier separation of the interstitial bridges. And the energy level of 112.20 nanojoules was relatively too low because at this level there was a high occurrence of black spots and areas. In study groups with low and moderate myopia, UDVA at the first day after SMILE using an energy level of 139 joules was significantly better than the using an energy levels of 159 joules. In the subgroups with high myopia, better UDVA the first day post-operation were obtained using an energy levels of 140 nanojoules. There were no statistically significant difference between the groups at follow-up. UDVA remains stable. The distribution of various degrees of OBL is listed in slide at the posterior and anterior plane of lenticle. In the group without OBL, there was significantly more UDVA 1.0 or better than in the group with OBL. The binary logistic regression method was used to estimate the probability of OBL occurring in patients. The following predictors were considered: K average, age, gender, spherical and cylindrical component, central corneal thickness, degree of myopia, femtosecond laser energy, and residual stromal thickness. The slide shows the formula for predicting the probability of OBL occurrence after SMILE. The results of our study suggest that an energy level, CCT, and myopia degree are an independent risk factor for OBL formation during SMILE surgery. These outcomes demonstrate that 140 nanojoules induce the smaller occurrence of black areas during treatment in patients with initially high myopia. Multifactorial analysis showed that the studied energy levels about 140 nanojoules didn't adversely affect the state of RMS total densimetry and total pachymetry, and there was also no dependence on the degree of myopia and the energy levels of laser. In addition, these results may indicate a higher degree of satisfaction and long-term quality of life in the patients with low and moderate myopia after SMILE with energy levels of 130 nanojoules compared to an energy levels of 140 nanojoules. No significant differences were found in the subgroups with high myopia. Conclusions. All the low energy level settings from 140 to 150 nanojoules achieved good visual outcomes. But energy level of 139 joules in patients with low to moderate myopia leads to higher UDVA on the first day and provides a significant improvement in quality of life 1 month after surgery. For high myopia, we recommend using an energy level of 149 joules. The results of our study suggest that an energy level, CCT, and myopia degree are an independent risk factor for OBL formation during SMILE surgery. Multifactorial analysis showed that the studied energy levels about 130-149 joules didn't adversely affect the state of total RMS, aberrations, densimetry, and pachymetry, and there was also no dependence on degree of myopia and the energy level of laser. Thank you for your kind attention.
Thank you very much. That concludes our session. Again, we bring our apologies for the next moderators and speakers, which unfortunately not our fault, but we still bear responsibility for that delay, and we hope you will be okay with this session. And thank you very much for your kind attention. We will make one photo of the group, and then we'll leave the stage and keep it to you. Thank you.